Hello, everyone, and welcome to our lesson on aneurysms and dissections. The truth is, guys, dissections are about as bad as things are going to get. When they happen, we really have only minutes or seconds to act, so we need to be able to recognize what's happening and how we're going to respond to it. We're going to talk about three specific conditions here: cerebral aneurysms, which are the leading cause of non-traumatic subarachnoid hemorrhages; aortic aneurysms, both thoracic and abdominal, the AAA; and aortic dissections, where really time isn't on your side, guys. We know what an aneurysm is, and if you don't, you can check out some of the med-surg lessons on nrsng.com in their neuro section and take that deep dive into aneurysms. But basically, it's the weakening of a vessel wall that causes sort of a ballooning out of the vessel, like right here, or actually right there. When it comes to cerebral aneurysms, there are really some very specific signs. The pain is crazy. It's sudden, it's intense, it's unrelenting. I've had patients tell me they feel like thunder and lightning are going off in their head, or they got hit with a baseball bat. It's bad. They can have an altered level of consciousness. They can become photophobic. So those fluorescent lights in the ER can be just brutal. Turn them off. They can have nuchal rigidity, and they can sometimes have nausea, which is going to lead to the inevitable vomiting. So with these patients, we want to get that immediate head CT, that CAT scan, to identify the location and the severity of the aneurysm. In aortic aneurysms, these patients complain about pain. It's in the back, the shoulders, and probably sometimes the chest or the abdomen. With that pain, they might also have some trouble breathing. And why? Well, because the swelling of that ascending aorta is putting pressure where there shouldn't be pressure. Depending on the size of the aneurysm, it can really determine the severity of the symptoms. Obviously, a bigger aneurysm, worse symptoms. Abdominal aortic aneurysms, or AAAs, we see some very specific symptoms. You may actually see a pulsating mass where the aneurysm is. And if you place your stethoscope over the spot where you hear that pulsation, you may actually hear a bruit, or that whoosh, whoosh of blood flowing through it. They might be tender to palpation over the abdomen. I mean, if that's your mass, yeah, you can probably feel that. And if you start pressing on it, they're going to feel that too. You can also present with some hematomas over the flank area if they're leaking a little blood into the flanks. So with dissections, there are some pretty classic signs. If we suspect an aortic dissection, you want to get a blood pressure in both arms. If they're actually dissecting, you can have a systolic significantly lower in one arm than the other. Usually, we take a minimum of 20 millimeters of mercury of one below the other. Sometimes you may not be able to get a pressure at all. They can have pulseless or pale lower extremities, and you have to remember, they have a hole in their aorta. So it stands to reason that blood is not getting where it needs to be. The separation of that vessel can actually cause ripping or tearing chest pain. And trust me, you're going to know it. They will be screaming in pain. They can also have an altered level of consciousness. Again, blood's not getting where it needs to be. Blood's not getting to the brain, not bringing oxygen to the brain. Altered level of consciousness. And overall, again, with the blood flow altered, they look terrible. They're pale, gray, diaphoretic. If we suspect any aortic involvement, we need to get some immediate diagnostics. Get that chest x-ray. All right, we're going to see a widened mediastinum sometimes. We can get the transthoracic echo, or the TEE, to kind of visualize the dissection. And if we have time, you're going to get the chest CT or the CT angio to see exactly what we're dealing with. So how do we treat them? Well, with cerebral patients, we first have to keep an eye on the airway. As their LOC goes down, they're going to have difficulty protecting their own airway, so we're going to have to secure it. And after we secure it, now we want to make sure we prevent further bleeding. So we want to maintain that systolic blood pressure between 90 and 140 millimeters of mercury. We can do that with any sort of mix of medications. Really always work with the docs and the physicians on that. With that pain, that searing chest pain, we want to give them some meds. They're going to have pain. Treat it. And also with that pain and that kind of tearing, insane chest pain, they're going to have that increased anxiety level. So we can consider giving some benzos, some IV benzos as well. We got to keep up our neuro assessments and possibly insert an ICP or an intracranial pressure monitor if we think the pressure is getting too big. If we suspect a rupture, OR. They got to have an emergency craniotomy. They got to open up their skull and relieve that pressure. So with the aortic aneurysms, much like our neuro cases, it's important to keep that pressure from getting too high. The more pressure there is on the vessel wall, the higher the risk of rupture. That being said, we don't want to decrease the pressure too low because if we do, we're going to decrease perfusion to the vital organs. I know there's kind of this delicate balance that has to be found in these cases. Many of the more severe cases are going to require surgery. Two of our main options here are the AAA resection, which is basically cutting out the aneurysm and rerouting the vessel, or they can have what's called an EVAR, right, which is an endovascular aneurysm repair. Endovascular aneurysm repair. This is where a stent is placed inside the vessel, and it prevents further pressure on the walls. If you look here, they slide the stent in, they open it up, and it kind of protects the vessel walls from further pressure. In dealing with true dissections, you got to move fast, guys. This is I hate to say life or death, but it really is. These guys have to move fast. Get them on O2. Get those 2 large bore IVs in. Do not mess with the 22 gauges. I want 16 gauge or better. Large bore IVs. They're going to need fluids, possibly blood products, and they're going to need them fast. So you want the large bore IVs. We need continuous monitoring of the blood pressure in both arms. As much as I don't like the automatics and I prefer manuals, in this situation, you want continuous monitoring. Put an automatic on both arms. And obviously keep an eye on any trends. In terms of meds, we want to give IV, nitroprusside or nitroglycerin to cause vasodilation. We're also going to give beta blockers to decrease contractility of the myocardium. Basically, we want to avoid putting any more pressure on the dissection, right? Pain meds are obvious here. And, of course, if they're truly dissecting, get them to the OR very quickly. They have to have a surgical repair of that dissection. All right, guys, we need to always remember our anatomy and physiology. If we suspect dissections or aneurysms, we need to know where they are and why they're happening. Perfusion is the key. We need to protect from bleeding, but we also need to make sure that we don't damage any vital organs. And much like with any of our ED cases, prioritization is the key. We may want to address that dissection first, but, is your patient breathing? Remember, ABCs, guys. Few key points here, guys. We need to identify when and or what and where the problem is occurring and what it is. Is it neuro? Is it cardiac? It helps to kind of know where that problem is. They're probably leaking somewhere, so be prepared to administer a lot of fluids. We talked about those 2 large bore IVs. All these cases are going to be in pain, whether it's neuro or cardiac. They all hurt. Don't be afraid to give them pain medications. In these cases, much like in any cases, it's the ED. We move quickly, but we also want to move efficiently. Everything we do needs to have a purpose. And in most cases, these patients are going to the OR. So make sure you can assist the docs in getting them packaged up and getting to the OR in a pretty timely manner. So thanks for joining us today, guys. Once again, be sure to check out all our other emergency medicine lessons here on nrsng.com. And as always, happy nursing.